Assalamu alaikum, dear students. Today we will talk about the subacromial bursitis. We will talk about the different bursa of the shoulder. And we will talk about what is bursa, what is the synovial fluid, and the general anatomy of a bursa, as well as we will discuss specifically subacromial bursitis different types, etiology of subacromial bursitis, as well as the examination, diagnosis, and the treatment of the subacromial bursitis. सबसे पहले बात करेंगे कि वर्षा है क्या चीज। वर्षा जो है दैट इज fluid filled sac found at several locations in the human body. और ये जो sac होता है इट इज मेड ऑफ द synovial membrane. Actually the जो वर्षा है दिस इज द एक्सटेंशन ऑफ द synovial membrane, and this membrane of the sac, this is not very thick, it's make up just few cell layer. और ये सेल जो इसकी मेम्ब्रेन बनाते हैं इस वर्षा की, and that is made of two type of cells. Both cells, they are known as the synoviocytes, but there are two types of synoviocytes, the type A and the type B. Type A synoviocyte and the type B synoviocyte. अब टाइप ए जो है ये इसको आप कह सकते हैं कि ये माइनोसाइट लाइक होते हैं। इसका मेन काम जो है ये डिब्रिस रिमूवल होता है, इम्यून डिफेंस होता है इसका। इसके अलावा जो है इसके जो टाइप बी है जिसको एंड दीज आर द मेन सेल्स, इसका मेन फंक्शन ये होता है कि इसके अंदर जो फ्लूइड होता है इससे के अंदर ये फ्लूइड जो है ये टाइप बी साइनोसाइट प्रोड्यूस करते हैं। न सिर्फ यहाँ पे कि ये साइनोवियल फ्लूइड प्रोड्यूस करते हैं, बल्कि जो बाकी मैट्रिक्स के लिए जो जरूरी कंपोनेंट्स वो सब जो है ये रिलीज करते हैं द टाइप बी सेल्स। सो वर्षा जो है इसकी हम बात कर ले कि जो फ्लूइड इनसाइड होता है ये वहाँ पे तब होता है जहाँ पे फ्रिक्शन और जहाँ पे वियर एंड टियर की बहुत चांसेस होते हैं। सो इसलिए ये वर्षा जो है ये एज अ लुब्रिकेंट के तौर पर काम करता है, एज अ कशन के तौर पर काम करता है। इट रिड्यूस द फ्रिक्शन बिटवीन द टू स्ट्रक्चर्स। और ये स्ट्रक्चर जो है मोस्ट कॉमनली ये एक मसल और टेंडन एंड बोन्स होते हैं, या बिटवीन टू मसल्स भी हो सकते हैं। जैसे लाइक सबकोराकाइड बर्सा जो है ये बिटवीन टू टेंडन्स प्रेजेंट होता है मोस्टली, एंड सबएक्रोमियल बर्सा जो है ये बोन और टेंडन के दरमियान प्रेजेंट होता है। सो और ये जो साइनोवियल फ्लूइड होता है जो इस लिब्रिकेट करता है, या यहाँ पे वी कैन से दैट कि ये कशनिंग का काम करता है या टेंडन और इसके दरमियान फ्रिक्शन रिड्यूस करता है। इसका फ्लूइड बिल्कुल विस्कस फ्लूइड होता है, विस्कस होता है, स्लिपरी होता है। आप इस तरह कह ले कि यू कैन कंपेयर इट टू द एग वाइट्स। जो सफेदी होती है ना एग की, बिल्कुल इसकी उसकी अपीयरेंस एंड टेक्सचर बिल्कुल उसी की तरह होती है। और ये फ्लूइड का काम सिर्फ ये है कि ये न सिर्फ यहाँ पे फ्रिक्शन को रिड्यूस करे, बल्कि यहाँ पे जो है इसकी मूवमेंट जो है ये भी स्मूथ हो। और इसके अलावा जो है ये वर्षा जो है ये कम्युनिकेशन के तौर पर भी काम करता है। इसमें बहुत सारे साइटोकाइंस होते हैं, प्रोस्टाग्लैंडिन्स होते हैं, हाइलुरोनिक एसिड्स होते हैं, और ये तमाम जो है इसकी खैर इसी हम इतनी डिटेल में नहीं जाती बिकॉज इट इज the composition and physiology of that fluid, but these components they are present inside this fluid. और ये जो synovial fluid इसका जो वाटर सब्सटेंस है या जो इसका मेन कंपोनेंट है, इट इज प्रोड्यूस एज एन अल्ट्राफिल्ट्रेट ऑफ द ब्लड प्लाज्मा। और ज्यादातर जैसे हमने कहा कि इसमें कंटेंट जो है ये हाइलुरोनिक एसिड होता है, ल्यूब्रिसिन होता है। लुब्रिसिन जो है ये ग्लाइकोप्रोटीन है, जबकि हाइलुरोनिक एसिड जो है ये ग्लाइकोस एमिनो प्रोटीन है। इसी तरह जो है प्रोटीनेजेस होते हैं, कोलेजिनेजेस होते हैं, प्रोस्टाग्लैंडिन्स होते हैं, डिफरेंट साइटोकाइन्स होते हैं। अम, और ये हम स्पेसिफिकली जो है हम सबक्यूमियल बर्सा की बात करेंगे। So subacromial space in the shoulder is such a location where a bursa is present between the acromion, under the acromion and above the tendon. So this tendon, this bursa is present just below the acromion. That's why this is known as the subacromial bursa. The height of the subacromial space ranges from approximately 1 to 1.7 cm, or from 10 millimeter to the 17 millimeter. बाज लिटरेचर में 15 मिलीमीटर भी देखा है, लेकिन 7 मिलीमीटर आपके जहन में होनी चाहिए कि अगर ये स्पेस जो है इफ इट इज लेस देन 7 मिलीमीटर, फिर वहां पे जो है इस बरसा की इम्पेजमेंट और इस बरसा की जो है इसको डैमेज करने चांसेस ज्यादा होते हैं। So this is the acromion we can see here, and this is the subacromial bursa. And this is the tendon, the supraspinatus tendon. So this subacromial bursa is present between the acromion and the supraspinatus tendon, and all these structures, the subacromial bursa, the supraspinatus tendon, and as well as the long head of the bicep tendon, which is anchored at the superior glenoid of the rim. All these are the components of this space known as the subacromial space, also called, we can call as the suprahumeral space. Now, what are the boundaries of the subacromial bursa? Superiorly, it is bordered by the acromion coracoid, the coracoacromion ligament, as well as the proximal deltoid muscle. And lowerly and inferiorly, it is being bordered by the uh, fibers of the supraspinatus muscle. So you can see here, this is that coracoacromial ligament, this is the acromion, this is the bursa, this is the supraspinatus tendon. So this is the top of the subacromial bursa, these ligament and the acromion and the coracoacromial arch, as well as the supraspinatus is the, or we can say the lower boundary of the subacromial bursa. There is another diagram showing the presence of the bursa just under the acromion and just above the tendon of the supraspinatus muscle. This is the tendon of supraspinatus. This is the muscle of supraspinatus. This is the subscapularis, and this is subscapularis tendon. This is the teres minor, and all these they combine together to form the rotator cuff. This is the short head of the bicep, the long head of the bicep. This is the bicipital groove. Now, what is actually this bursitis is? So it is an inflammatory condition of the subacromial bursa, which developed due to the unaccustomed overuse causing shoulder pain. Discriminating characteristic of acute subacromial bursitis is pain and at the wrist, which is aggravated by almost all shoulder movement. और यही एक डिफरेंस होता है between the subacromial bursitis and the sub-impingement syndrome. Usually in the sub-impingement syndrome, there will be no such pain when the patient is at rest, when the shoulder is at neutral position, and there will be mostly pain, increase in the pain intensity with the internal rotation and elevation, while there will be release in the pain, there will be some relief in the pain, decrease in the pain intensity with the external rotation, specifically in the subacromial impingement syndrome. But if this is the subacromial bursitis, then the pain will be present at the wrist and it will be aggravated by almost all shoulder movement. There will be no such relief. The similarity between these two is that both have the same painful arc. Just we have discussed in the subacromial impingement that the painful arc will be from the 60 to 120. There will be no such pain below 60 degree and no such pain in after the 120 of elevation. तो अब बात करते हैं बाकी वर्षा की, जो रिलेवेंट एनाटमी है। द शोल्डर रीजन में 6 वर्षा है जो काफी ज्यादा, और दिस इज वन ऑफ दोज जॉइंट व्हिच हैविंग द मोस्ट एंड abundant several bursa in the surrounding. These they can be divided into the major bursa and minor bursa, or simply we can say that कि कुछ bursa ऐसे होते हैं कि इनकी रोल बहुत इंपॉर्टेंट होते हैं और कुछ इतनी इम्पोर्टेंट नहीं होती उसकी रोल. So that's why जो important one है they can be called as the major bursa, and they are four in number. This is the subscapular bursa or the scapulothoracic bursa, the subdeltoid bursa, the and then the subacromial bursa, the subcoracoid bursa. सब डेल्टाइड सब इक्विपमेंट जो है इसको समटाइम कंबाइन भी बाद लिटरेचर में इसको यूज किया गया है, द सब डेल्टाइड सब इक्विपमेंट बर्सा. The subacromial and the subdeltoid bursa are often taken as a single bursa, as we discussed. Subscapular bursa की बात करते हैं, which is also known as scapulothoracic bursa or subscapularis recess. We can see here that this is the subscapularis recess, that is this present between the tendon of the subscapularis muscle and the shoulder joint capsule. So this is the subscapularis muscle, and this is the grenade, and here it is just the joint capsule surrounding here. So this subscapularis recess is present between the humeral joint capsule and the subscapularis. The subdeltoid bursa that is present between the deltoid muscle and the shoulder joint cavity, and it reduces the friction of that uh, deltoid when the deltoid muscle is in action. This is the deltoid bursa. This is the subacromial bursa. Both have been combined together, shown here in together form. So that's why this can be called as the subacromial deltoid bursa. This deltoid bursa is the largest bursa of all these 6 bursa in the shoulder region. The subacromial bursa, which is our point of interest, this is present below the acromion process and above the greater tubercle of the humerus, and it is present between the acromion and the supraspinatus tendon. Its main function is to reduce the friction in the space under the acromion. The subcoracoid bursa. The subcoracoid bursa that lies between the coracoid process and the combined tendons of the short head of the bicep and the coracobrachialis, as we can see here. This is the subcoracoid bursa, and this is the combined tendon of the short head of the bicep and the coracobrachialis. It is superior to the subscapularis tendon. This bursa decreases the friction between that subscapularis tendon and the tendon of the short head of the bicep and the that coracobrachialis. So this is, as we discussed earlier, that this bursa, subcoracoid bursa, is present between these two tendons, and that's why it's reduced the friction between the short head of the bicep and the subscapularis. Specifically, when there is rotation of the humeral head, both the internal rotation and internal rotation. So we can say that this subcoracoid bursa, this is very crucial and this is very important as it facilitates both the internal and external rotation of the shoulder. Uh, this subcoracoid bursa that does not communicate with the shoulder joint directly. Here we can see there is no such direct communication with that shoulder. However, it may have a communication with the subacromial bursa. और इसी वजह से ड्यूरिंग सब कोराकोइड bursitis जो है the passive external rotation in 90 degree of abduction is negative and the passive external rotation in 0 degree span. Sometime in this coracoid subcoracoid bursitis, a constant in this condition. A contrast fluid is injected into the glenohumeral joint. Thus, normally it will not show some that subcoracoid bursa during lithography. But if it is present, it will show the full thickness of that subscapularis bursa. As well as this subcoracoid bursa, when it is inflamed, it is a strong association with the rotator cuff tear. So a woman, when there is sub rotator cuff tear, so we can also check the subcoracoid bursa as well. Otherwise, subcoracoid bursa is very rare to be involved in the pathological condition. And on this bursa, the most commonly involved bursa, uh, which is very prone towards inflammation. This is the our bursa, which is under our study in our session. And this is the subacromial bursa. This is the subdeltoid bursa. Then this is the uh, subacromial bursa, which is just under the acromion. This is the subcoracoid bursa, which is under the acromion, and this bursa is actually present between the subscapularis and the other two tendons which are attached to the coracoid process. Both the short head of the that bicep and the coracobrachialis, they are attached to the that coracoid head, a coracoid process. And here, this is the subscapularis tendon. So this bursa is actually present between these two tendons. As we discussed previously, this subcoracoid bursa that has no such direct communication with the shoulder, but as it is very closely related to the rotator cuff tendons, and that's why it is a strong association with the rotator cuff here. The other bursa which are not so important, but they are present is the shoulder region. They are the infraspinatus bursa, which is present between the infraspinatus tendon and the capsule of shoulder joint. The subcutaneous acromial bursa or the supraacromial bursa. That is subcutaneous means that is just present under the skin, and supraacromial, this is opposite of the subacromial, and this bursa is present above the acromial process. So that's why known as the supraacromial bursa, just beneath the skin. Now we'll talk about the etiology behind this subacromial bursitis. Floor of the bursa is the supraspinatus tendon, and the roof is the acromion. Inflammation of this bursa is most commonly the result of the repetitive strain or injury to the other structures like the rotator cuff. And that's why there is a very strong association between the rotator cuff tendonitis and the subacromial bursa. There are other several factors that could be related to the bursitis, like the trauma and in the joint inflammation. Due to an accident, the bursa could become irritated and they can eventually become inflamed. Similarly, when the whole joint is inflamed, the bursa can become inflamed as well as the other structure, like in the condition like the osteoarthritis or the gout. Another mechanism for this bursitis is the overload. This repetition of a certain motion too often can lead to the inflammation of the bursa because of the that repetitive friction between the bursa and the one on the one hand and another structure on the other hand, which is actually obviously the tendon. So this can be a tendon, bone, or ligament, but most commonly this is actually the tendon. Cervical bursitis rarely occurs alone, and it is usually associated with the supraspinatus tendonitis, tenus lanuitis of the rotator cuff, occipital muscles, or the glenohumeral arthritis. हमने जैसे पहले भी डिस्कस किया जब हम कोराकाइड डिस्कस कर रहे थे कि इस तरह को सब कोराकाइड बर्सा जो है ये भी अमूमन प्रेजेंट होता है when there is rotator cuff tendonitis or tear in the rotator cuff tendon. Similarly, ये subacromial bursa जो है ये भी अमूमन जो है प्रेजेंट होते हैं along with the other condition like the inflammation of the supraspinatus tendon or the inflammation of the sheath covering the tendon of the rotator cuff. Similarly, that the sheath of the bicepnosis and during the different arthritis or gout condition there may be. And gouty arthritis is actually the cause of the bursa. So that's why these both are present at the same time, simultaneously. And that's why, because of all these presence of multiple conditions at the same time, a detailed and very comprehensive thorough history is very crucial to distinguish the bursa from a supraspinatus strain or involvement of the other rotator cuff structures. Some common etiologies, other etiologies which can lead towards the subacromial bursitis, that is the most commonly involved, the subacromial impingement, the repetitive overhead activities are overuse of this muscle, direct trauma, crystal deposition, specifically the calcium deposition, subacromial hemorrhage, infection, and autoimmune disease like the rheumatoid arthritis. Now, let's discuss some epidemiology of this subacromial bursitis. Bursitis account for approximately 0.4% of all primary care visits. Gender prevalence is almost equal. It is seen more often in individuals who participate in repetitive poor activities such as athletes, factory workers, and manual laborers. Older individuals are more prone to experiencing subacromial bursitis, likely due to years of wear leading to an increase in the subacromial impingement. हम अगर इसकी पैथोफिजियोलॉजी के बारे में बात की तो यहाँ पे समटाइम इस तरह होता है कि जब सब इस एक सभी बर्स की इंफॉर्मेशन हो जाती है तो जैसे हमने पहले भी डिस्कस की देयर आर मेनी अदर डिजीजेस which will lead to the cervical bursa, but there will be common result and of this bursa is that they will be increase in the fluid. जो यहाँ इस बरसा जो है इसके अंदर जो फ्लूइड होता है इसकी ये इंक्रीज इसलिए होता है कि वहां पर जो टाइप बी साइनोसाइड्स होते हैं ये दे इंक्रीज मोर एंड मोर फ्लूइड जस्ट ए रिस्पॉन्स टू द प्रोस्टाग्लैंडिन because prostaglandin जो हैं they are that chemical substance present in which communicate when there is inflammatory substance. So there is more and more abnormal fluid secretion जिसकी वजह से उस जगह पे स्वेलिंग हो जाती है because of that increased fluid. इसी तरह जो है कोलेजन फॉर्मेशन जो है ये भी ज्यादा हो जाती है एंड बाय द सानुअल सेल्स ऑफ द पर्सन. तो ये जो सानुअल सेल के बाद यहाँ पे है दिस इज एक्चुअली द टाइप बी सेल्स और इन सानुअल सेल्स को कहा जाता है द सानुसाइट्स. So the type B cells they form in more and more fluid and more collagen. Similarly ये जो है ये fluid ये hyaluronic acid जो है ये भी ज्यादा create करते हैं and openly when there is more increase in the fluid so there is also increase in the uh, presence of that fibrin और इस fibrin की वजह से जो है इस ईरा जो ये हेमरेजिक भी हो सकती है. इसी तरह जो है ये स्वेलिंग जब हो जाती है तो जैसे हम इसको किसी भी डायरेक्शन में शोल्डर को मूवमेंट देंगे तो उससे उसी सबक्यूमिल बरसा पर जो है प्रेशर पड़ेगा and that will become painful. When it is in the acute stage, even there is no movement, still there will be a painful condition. Another difference between the cervical impingement and the bursitis is कि bursitis वाली जगह पर अगर हम हाथ रखें तो ये थोड़ा सा गर्म होगा वार्म होगा एज कम्पेयर टू द अदर शोल्डर. इसी तरह जो है ये थोड़ा सा पाल्पेशन पे पेन ज्यादा मिलेगी एज कम्पेयर टू द impingement. वहां पर इतना पेन नहीं मिलेगा when we palpate that area. Similarly, इस जगह में redness भी जो है बहुत ज्यादा है because that is a pure inflammatory process. So that's all the cardinal signs of the inflammation, which is the pain, swelling, the redness, and warm temperature. So that thermal sensation is तमाम की तमाम वहाँ पे present होगी. बर्साइटिस को जो है हम 3 फेजेस में डिवाइड करते हैं. दिस इज द एक्यूट, chronic and recurrent. The acute phase, this is marked by local inflammation, and there is more viscous synovial fluid in the acute phase because of the high concentration of the component in the fluid, and that's why there is more viscous and more thickened. This condition result in painful movement, particularly with overhead activities. एंड अमूमन पेन जो है ये तमाम एक्टिविटीज में होती है. इवन अगर आप एक्सटर्नल रोटेशन करते हैं, इंटरनल रोटेशन करते हैं, abduction करते हैं, एक्सटेंशन करते हैं, या फॉरवर्ड फ्लेक्शन करते हैं, so there is a pain at that area. As the bursa undergoes friction between the humeral head and supraspinatus inferiorly and the crumen and deltoid superiorly. In the chronic phase, वहां पे जो है पेन जो है ये कांस्टेंट हो जाता है, बट दैट इज लेस इन इंटेंसिटी देन इन द एक्यूट फेज. और यहाँ भी जो पेन है इसका मेन मैकेनिज्म जो है, दिस इज द क्रोनिक इन्फ्लेमेटरी प्रोसेस व्हिच इज अकरिंग इन द बर्सा. और सम टाइम इस तरह हो जाता है कि इसी कांस्टेंट पेन और इस क्रोनिक इन्फ्लेमेटरी की वजह से वीकनेस एंड इवेंचुअल रप्चर ऑफ द सराउंडिंग लिगामेंट्स एंड टेंडन ये भी हो जाती है, specifically the supraspinatus tendon. In case of chronic bursitis, attention must be paid to tendinitis, since these entities they can be present simultaneously, specifically the supraspinatus tendinitis and the bicep tendinitis. Recurring phase, these recurring phase they can occur in patient exposed to repetitive trauma or routine overhead activities. It can also present in patients with inflammatory conditions such as the rheumatoid arthritis. Now, what are the characteristics or the clinical presentation? अगर एक patient suppose आता है with the pale subacromial bursitis, तो उसकी clinical symptoms क्या क्या होंगे? सबसे पहले जो है उसको सबैक्रोमियल साइड पे पेन होगा, आर्म वीकनेस होगी, आर्म स्टिफनेस होगी, और स्टिफनेस और जो है इसलिए होगी उसकी कि क्योंकि वो जैसी किसी भी डायरेक्शन में हाथ को मूवमेंट कर देता है तो उसको पेन होता है. उसकी वजह से वो हाथ को जो है कोशिश करता है कि वो अवॉइड करे इसकी मूवमेंट. उसकी वजह से स्टिफनेस जो है ये आ जाती है. वीकनेस क्यों होती है? बिकॉज देयर में बी द इन्वॉल्वमेंट ऑफ द टेंडन्स, जो उसकी वजह से वहां पे थोड़ी बहुत वीकनेस जो है हो जाती है. शोल्डर स्वेलिंग होगी एंड शिवर्स होगी बिकॉज इफ देयर इज infection. Now ये तो इसके symptoms हो गए. Now what are the signs of the subacromial bursitis? There will be subacromial tenderness, और ये tenderness जो है ये ज्यादा होगी as compared to in the impingement syndrome. कि impingement syndrome में अगर हम palpate करें तो might be there may be pain, but इतना नहीं होगा जितना पेन subacromial bursitis में होगा. सिमिलरली सभी क्रूमिन इम्पीचमेंट टेस्ट जितनी भी होंगी वो सब के सब पॉजिटिव होंगी, क्योंकि उन टेस्ट से जिस तरह टेंडन पर स्ट्रेस पड़ता है, इसी तरह उसमें इस बर्सा पर भी जो है स्ट्रेस पड़ता है. एंड दैट्स व्हाई all the tests which are positive in the subacromial impingement syndrome, almost all of them they will be positive as well in the subacromial bursitis. Apparent or true weakness, later if it is weighted rotator cuff tear. Apparent weakness से मुराद ये है कि there is no such actual weakness in the muscle. All the muscle are okay. That is just the pain. जिसकी वजह से the patient is showing some weakness. That is known as the apparent weakness. True weakness से मुराद ये है कि अगर यहाँ पे actually the tendon is there is tendon tear हो चुकी है, strain हो चुकी है, तो उसमें जो है obviously फिर there will be true weakness. Apparent or true stiffness, again if there is जब movement initially पेन की वजह से जो है सिर्फ मूवमेंट नहीं कर सकता तो stiffness is apparent, but when apparent stiffness they lead to the true stiffness when adhesions जो है ये वहां पर क्रिएट हो जाती हैं और पूरी इम्प्लीमेंटिव प्रोसेस जो है ये स्प्रेड होती है इनटू द शोल्डर, तो ऑब्वियसली फिर वहां पे पूरी जॉइंट जो है ये स्टिफ होगा और वहां पर एडिस्टिक कैप्सुलाइटिस की भी चांसेस हो सकते हैं. सो इफ देयर इज नो सच एडिस्टिक कैप्सुलाइटिस, or no joint inflammation. So then there may be only the apparent stiffness, which is mean there will be the stiffness and limitation of the movement just because of the pain intensity. जैसे ये पेन सबसाइड होगा उसकी मूवमेंट जो है ये वापस ऑलमोस्ट नॉर्मल हो जाएगी. Muscle wasting जो है कि chances है if it is situated with the rotator cuff tear, fullness of the subacromial space, obviously because of the swelling जो है वर्षा, इस swelling की वजह से जो space है कि इसकी stenosis हो सकती है, ये fill हो सकता है. And if it is infectious, obviously there will be pyrexia as well. Now, in the clinic, what are the common historical findings we will meet when we assess the patient with subacromial bursitis? There will be diffuse shoulder pain, there will be pain at wrist as well, and there will be recent unaccustomed repetitive use of the upper extremity. This is the physical examination procedure, the palpation of the subacromial bursa. This is the area just below the acromial process, and it will provoke the pain. And if in this position, if we palpate that area, so if there is bursitis, they will be increase in the intensity of the pain. और ये जो टेस्ट है जिसे हमने पिछले डिस्कस किया कि अमूमन जो टेस्ट which are positive in the subacromial impingement syndrome, they will be also positive in the subacromial bursitis. तो उनमें से एक पेनफुल आर्क है और ये पेनफुल आर्क का मतलब ये है कि अगर हम इसकी एबडक्शन करें तो ये पेशेंट जो है 60 के ऊपर 60 तक जैसे पहुंच जाता है और इससे जैसे ऊपर जाएगा so there will be pain and the pain will continue until 120. 120 के बाद जो है पेन गायब हो जाएगा. तो इसकी मेन रीजन ये है कि 120 के बाद जो है there is no such pressure and stress on the subacromial space and hence there is no such tension and stress on the tendon and bursa. लेकिन अगर 120 के बाद पेन आ रही है so mostly it is because of the AC joint involvement. और 60 डिग्री से नीचे भी जो है जब एबडक्शन करते हैं so there is no such stress or pressure on the tendon, supraspinatus tendon and the subacromial bursa. So when lowering from the full abduction up, and there is painful catch at the mid-range, and this is known as the catching sign. Catching sign is also positive in the subacromial impingement syndrome. If the patient can achieve adequate muscle relaxation, passive motion tend to be less painful. Speed test, this is an isometric test, and the patient performs an isometric flexion contraction against the resistance of the therapist. When the therapist resistance is removed, a sudden jerking motion results, and the latent pain indicate a positive test for bursitis. Usually, the speed test is basically made and used for the assessing the bicep tendonitis. Near sign, which is positive in the subacromial impingement syndrome, is also positive in the subacromial bursitis. So pain occurs during the forward elevation of the internally rotated arm above 90 degrees. It is considered as a positive sign for the subacromial bursitis. And near sign is one of the most sensitive tests among all that is used for the impingement and bursitis. This is the near sign, 90 degree of abduction, and then there is addition of internal rotation. It will lead to the compression of both the bursa and tendon. So that's why if there is bursitis or tendonitis, in both cases there will be a positive sign. This is the Hawking test, also known as the Hawking Kennedy test. सिंपल उस टेस्ट में और इसमें सिर्फ डिफरेंस ये है कि वहाँ पे इस Hawking Kennedy टेस्ट में हम एल्बो की फ्रिक्शन जो है ऐड कर लेते हैं. बाकी इसके भी हम 90 डिग्री पे लेके आते हैं and then we add the internal rotation of the shoulder, and if there is increase in the pain या patient report करता है कि the pain is being increased, then is a positive sign for the subacromial bursitis. This is the EMT test which we have discussed in detail in the previous lecture. Now, what will be the physical examination finding if the patient is in the acute stage? So what examination finding we will meet. So the protection of the shoulder and avoidance the use of the injured arm, and that's why there will be apparent stiffness at the shoulder. Unable to fix or abduct the shoulder or reach during the overhead activities secondary to pain. In between, there will be much more and pain condition, and all the shoulder movement, the pain will exaggerate. And that's why, because of this aggravation of the pain, he will not use or will avoid the shoulder movement. Apprehension with all shoulder movement because of the pain. If there is elevation, if there is friction, abduction, or extension, in all cases, there will be stress on the that swell person, and that's why the person will avoid to move the shoulder in any direction. Symptoms are reproduced or increased with palpation of the subacromial bursa. There will be more pain, there will be more tenderness and palpation. During the subacute stage, when the condition is in the moderate level, the symptoms they are provoked only at the end range of the active abduction. In the initial moment, in the initial abduction, initial fusion, there below 60, there may be no such pain increase, but at the end range of that, usually at the 90-degree, there may be increase in the pain intensity. Similarly, there will be pain with the resisted abduction or flexion of the shoulder, and painful arc of the range of motion for the bursitis is 60 to 120 up abduction, and usually in this subacute stage, the pain will be present at the 80 to 90 degree. Resisted test may be weak and painful due to the compression and inflamed subacromial bursa by contracting deltoid muscle and involvement of the rotator cuff tendon and muscle. Similarly, the impingement sign, they may help distinguish between the bicipital tendonitis and bursitis, because in the impingement sign, the tests which are positive, if it is the bicipital tendonitis or the impingement sign will be negative. And in the bursitis, all the impingement signs will be positive. The later subacromial tenderness suggests bursitis or the supraspinatus tendonitis, while the interior subacromial internal suggests the bicipital tendonitis. So यहाँ पर हम इन दोनों में ये डिफरेंशिएट कर सकते हैं कि laterally अगर हम करें, so there will be both the supraspinatus and tendonitis and subacromial bursitis, जबकि interior जो है that will be a positive sign for the bicipital tendonitis. Similarly, arthritis may cause us to fight calcium projection into the bursa, calcific bursitis. In this subacute stage, limitation in function activities include difficulty in sleeping on the involved side, grooming, specifically that internal rotation, dressing, work, and sports activities. What are the other conditions which are usually present along with the subacromial bursitis? The cervical and upper thoracic segmental movements abnormalities may be present. Similarly, both the physiologic and accessory movements of the shoulder joint, they may be limited with the subacromial bursitis. Similarly, there may be some muscle flexibility deficit, specifically the subscapularis, the infraspinatus pectoralis minor, and major latissimus dorsi and the teres major. There may be nerve mobility deficit as well, including the median, meridian, ulnar nerve. So they should be included in the that examination, and they should be excluded either there is any nerve mobility deficit present or not. Some muscles may be weak during if the patient is with the subacromial bursitis, and these muscles are the lower trapezius, middle trapezius, and the serratus anterior. There may be excessive scapular elevation just because of the imbalance between the lower trapezius and the upper trapezius. As the lower trapezius, they are weaker in the subacromial bursitis, so there will be dominancy of the upper trap, and that's why there will be more elevation of the scapula. There will be more excessive abduction as well, and downward rotation or winging with overhead activities. Winging क्यों होगी? Because swinging जो होगी, there will be because of the weakness of the serratus inferior. and that serratus interior that will lead to the type 2 winging or the type 2 scipiodyskinesis, जिसकी वजह से पूरा entire medial border जो है ये prominent हो जाएगा, specifically with the internal rotation. If it is the chronic stage, then there may be some radiographic sign as well, and they will include the narrowing of the acromihumeral gap, वहाँ पे stenosis होगी. There will be superior subluxation of the humeral head and erosive changes at the inferior spectra of the acromion. These are the upward and downward rotators, which we have discussed in detail in the previous session. These are the different movements of the scapula. Now, when the patient is in the settled stage, when it is in the mild condition, when the pain has much subsided, pain is in the mild category, uh, so the pain will only be present when there is repetitive activities. When the person do an activity again and again, there may be the aggravation of pain. Otherwise, there will be no such pain, and the once or twice repetition of that activity, including both the abduction and friction. Similarly, there will be no such pain in the if the word activity is just conducted once. अगर वहां पर हुआ प्रेशर दे दे या हम वहां पे पैसिवली फोर्स करिए रेंज शोल्डर फ्लेक्शन पे, जिस तरह इम्पेचमेंट टेस्ट में होता है, सो माइट भी पेशेंट की पेन जो है ये एक्सेजरेट हो जाए. इसी तरह उसकी जो डिफरेंट रेजिस्टेंस टेस्ट होते हैं दे आर पेन फ्री, और अगर हम इसको मिड रेंज पे करें, पेन ओनली विद रिपीटेड फ्रिक्शन एंड रिट्रैक्शन कंट्रैक्शन. सो एक्यूट में सिंपल एक दफा मूवमेंट जो है किसी भी डायरेक्शन में मूवमेंट से उसको पेन अमूमन होता है, जबकि सभी क्यूट में इवन पेन जो है ये सिर्फ एंड रेंज में होता है, जबकि सेटल स्टेज में इवन देयर इज नो सच पेन एट द एंड रेंज, एंड पेन तब एक्सेजरेट होता है व्हेन देयर इज repetitive movements. Now, what intervention approaches we can use for a patient with subacromial bursitis? So that depend on what is actually the condition and situation of the patient. If the patient is in the acute stage, then our goal is to decrease the pain intensity. क्योंकि ये acute के फेज में सबसे मेन जो प्रॉब्लम पेन होती है, और इसी पेन की वजह से might be there is some apparent weakness of the rotator cuff tendon. There may be some apparent stiffness as well in the shoulder. So that's why we have to make the person pain-free at least at rest. So for that, we can use the different physical agent approaches like the phonophorosis, ionophorosis, or pulse ultrasound as well to assist in reducing inflammation. We can also use the ice for reducing the swelling, for reducing that inflammation. Icing can also be used to reduce the pain intensity. Similarly, there are some studies which have reported that TENS can also be used for the relief of that acute pain, as well as the TENS also help in the releasing of the muscle guarding. So, and this is a normal phenomena when there is some inflammatory conditions. We can also use some external devices like the taping, splinting, or orthotics. We should consider a sling if it is necessary, because it will lead to the temporary block of some movements, and specifically those movements which exaggerate that shoulder pain, like the shoulder flexion and the internal rotation. Some therapeutic exercise can be used, as we have discussed in detail in these therapeutic exercises in the previous lecture, when we were discussing the subacromial impingement syndrome, like the Cordman exercises, the pendulum exercises, and free passive range of motion, active assisted range of motion, or the active range of motion exercises once or twice a day. We can temporarily limit the flexion, abduction, and elbow activities just to prevent further injury just to prevent further worsening of the surrounding structures. When the patient is in the subacute or in the moderate conditions, so then obviously the pain would be not present at rest. The pain would present only with the movement, or that will be present in the end range of the movement. So that's why the goal of that subacute stage should be to make the person pain free with active movement. For that, we can use different therapeutic exercises like there will be progression in the active range of motion exercises to that limit when there is pain free, and the active range of motion exercises progress to the weighted supine and sitting shoulder flexion, abduction, and rotation strengthening program. Similarly, we can incorporate the manual therapy at this stage as well, like the soft tissue mobilization. Those muscles who are short, like who are having the flexibility deficit, like the subscapularis, infraspinatus, both minor and major of pectoralis, latissimus dorsi, and the teres major. Similarly, we can incorporate, we can give provide the joint mobilization and attempt to normalize the accessory mobility or the physiologic function of the that green humerus joint. When the patient is in the chronic stage or in the settle stage, or when the condition is mild, then the main goal is to make the patient pain free with repeated active movement, क्योंकि सिटर स्टेज और माइल्ड कंडीशन में पेन जो है ये एग्रीवेट होता है with repeated active movements. So the different therapeutic exercises like to strengthening and endurance exercises. Similarly, we can maximize the muscle performance of the relevant trunk, scapula, and shoulder girdle muscles. We can also work on the ergonomic aspect of that patient, and that is these are the references to which have been used to construct these slides. Thank you so much to all of you. Allah Hafiz.